Hello everyone, in this video we're going to be discussing nephrogenic versus central diabetes insipidus. Now, nephrogenic diabetes insipidus is going to be due to a mutation in the V2 receptor. The V2 receptor is a receptor that is going to be found on the basolateral membrane on the collecting tubules of the kidney. Let's draw this out. So here is the V2 receptor on the basolateral membrane of the collecting tubule in the kidney, and the V2 receptor binds antidiuretic hormone. Right? So when we are dehydrated, for example, our serum osmolality is going to be high. And when it is high, in order to bring it down, we don't want to lose more water. Instead, we want to reabsorb water so that we can bring our serum osmolality down. And the way our body does that is by the release of the antidiuretic hormone from the posterior pituitary. And when we release this antidiuretic hormone, it binds to the V2 receptor on the basolateral membrane of the collecting tubule, and then we're able to put aquaporins on the apical surface, and this way we're able to reabsorb water. As we said, nephrogenic diabetes insipidus is a problem in the kidney, so nephrogenic for kidney, where there is a mutation in the V2 receptor. As a result, antidiuretic hormone is not going to be able to bind to the V2 receptor to put aquaporins on the surface of the apical membrane, and then as a result we're not going to be able to reabsorb water, so water is going to be lost in the urine. With central diabetes insipidus, what happens is there's a problem in the central nervous system. So central for the central nervous system, where the posterior pituitary is not able to secrete antidiuretic hormone. So it's a problem with antidiuretic hormone secretion. So because we have low levels of the antidiuretic hormone, we're not going to be able to put aquaporins on the apical surface. As a result, we're going to be losing water. So in both of these diseases, patients are going to present with polyuria because they're not going to be able to concentrate their urine. So the urine is going to have a low osmolality. These patients are going to have a high serum osmolality. Why? Because they're not able to reabsorb water through those aquaporins in order to bring their serum osmolality down. And also these patients are going to present with dehydration. Now let's discuss how we can differentiate between these two diseases. So a patient comes with some type of diabetes insipidus, but we need to distinguish between these two diseases. So first, let's talk about what a normal person would exhibit in a water deprivation test. Water deprivation test is the test we're going to use to distinguish between central and nephrogenic diabetes insipidus. So in a normal person, the baseline serum osmolality is going to be normal. And when we deprive a normal person with water, they're going to be releasing antidiuretic hormone, and the antidiuretic hormone is then going to reabsorb water, and we're going to have concentrated urine. As a result, the urine osmolality is going to go up. If we give that person desmopressin, which is an antidiuretic hormone, there's not going to be any changes in the urine osmolality because that person already has antidiuretic hormone on their own. So now let's talk about central diabetes insipidus. Remember, central diabetes insipidus is a problem in the central nervous system with the secretion of the antidiuretic hormone. And their baseline serum osmolality is going to be high. So a high serum osmolality. Now, if we conduct a water deprivation test where we deprive a patient with central diabetes insipidus of water, what we see in their urine osmolality is we don't see any changes. Why? Because that patient does not have antidiuretic hormone. Even if you deprive the person of water, they're not going to be able to release antidiuretic hormone to concentrate their urine. So as a result, what we see is no change in their urine osmolality. Now, if we give the patient with central diabetes insipidus desmopressin, which is an antidiuretic hormone, we are essentially fixing the defect. As a result, the urine osmolality is going to go up with desmopressin. Now let's talk about what happens in a patient with nephrogenic diabetes insipidus. So the baseline serum osmolality again is going to be high because these patients are dehydrated. And when we deprive a patient with nephrogenic diabetes insipidus of water, there's not going to be any changes to the urine osmolality. Why? Because they have a mutation in their V2 receptor, so antidiuretic hormone is not going to be able to bind appropriately to that receptor in order to put aquaporins to your absorbed water. As a result, they're not going to be able to concentrate the urine. If we give these patients antidiuretic hormone, there's not going to be any changes again because the problem is within the receptor itself, not with the hormone. So remember, these patients have no trouble producing antidiuretic hormone. The problem is with the receptor found in the collecting tubules because it's not responding to the antidiuretic hormone. As a result, even if we give these patients desmopressin, we're not going to see any changes in their urine osmolality.